I would like to thank ARC team for having me here. Retinal diagnostics includes fundus photos, B-scan, FFA, OCT, autofluorescence, OCT angio, ICG angiography, ERG, and VEP. Why retinal diagnostics are required? Because to what we see clinically to confirm the diagnosis and to differentiate diagnosis, to rule out some differential diagnosis, and by diagnosing a condition, what is the prognosis of that condition and what is the treatment that is applicable for that particular condition, we have to determine by this retinal diagnostics. For all residents who see in the OPD, by clinical examination, it should be supported by the investigations, and all the retinal investigations, whichever that come, B-scan, FFA, OCT, will have its own learning curve. It takes some time to learn. So to start as early as possible, the learning the things is very good, and patient satisfaction by doing investigations will improve the confidence of residents. And B-scan, the most common indications being corneal scars, occlusio pupils, total cataract, and vitreous opacities. In all, we will discuss in further class. These should be basic things among the many things. This is just drop of ocean, a few conditions here, and we will see all the conditions. We will have didactic lectures by eminent speakers in coming 4 days, and these are the few conditions where we do B-scan. And this is one is a total corneal scar, mature cataract, occlusio pupil, endophthalmitis, vitreous hemorrhage, and B-scan. How to do a B-scan? We will see all these things in coming days by didactic lectures. And there are few basic things. This is for only residents. If you become a retina expert, then we have to see many more things. These are the few basic things we have to see in a B-scan by the resident, and in the FFA also. A few most common conditions where we do FFA by residents is diabetic retinopathy, vein occlusions, ARMD, and CSCR. And phases of this is a star mark question for every resident. We must learn all these things and how to interpret the FFA and diabetic retinopathy. By doing all these things in the residency itself will increase our clinical knowledge, and this should be performed by all the residents. This is wet AMD. And OCT also, if not many institutes are having OCT, if at all having, this should be learned by resident in the residency itself, because all the layers, because OCT is useful not only for posterior segment, and it is useful for glaucoma and also anterior segment. We can see all the layers of retina. And with the advent of OCT, FFA use is a little bit less, because FFA is invasive, and whereas OCT is non-invasive, and it is very fast, and it can be done in non-mydriatic people also. And the few basic things we have to see in OCT this is for resident level. So vitreomacular traction, intraretinal fluids, subretinal fluids, and intraretinal hemorrhages and hot X-rays, that is ISOS junction and RPE integrity and structure.
Last 1 minute.
Yes. And these are the few common indications for OCT. And what we see clinically, this is the most common things what we see in regular our own OPDs. So these things should be learned by residency itself. And VEP and ERG interpretation, or if some patient brings out the printout of VEP or ERG, how to read it. Otherwise, many of them only research institutes will do this, and not routinely. And retinal diagnostics include the X-ray, CT, and MRI of brain and orbits to rule out foreign bodies. And this is a fracture of orbital apex, which leads to optic atrophy. And MRI in case of thinning of optic nerve, leading to optic atrophy. These things, at least we in the residency itself, if you can learn few things, we can have more confidence in our practice. So my take-home message is, learning retinal diagnostics is must for residents. The basic things includes the B-scan and FFA and OCT, apart from X-ray, CT scan, and MRI orbits, a few basic things. Thank you very much for giving me this opportunity.